Welcome, everyone, to the RadOnc Smart Review GYN Cancer Series.
Great to be diving into this topic today.
Absolutely. Today, we're tackling a really critical update, aren't we? It's
Yeah.
all about cervical cancer management.
Exactly. We're focusing hard on the new standards, especially for, locally advanced disease, and also importantly for recurrence.
Right. This is key if you're prepping for boards or, honestly, just anyone trying to stay current with the big practice changes from, 2023, 2024?
Yeah, the really practice-changing evidence.
We're definitely moving past the absolute basics today. The aim is really focusing on the upgrades, the things that have genuinely shifted how we approach this.
Yeah, because for, 2 decades, the foundation was pretty set, wasn't it? Concurrent cisplatin chemo RT.
The standard.
The absolute standard. And look, that's still the backbone. It hasn't vanished, not at all. But what we're really digging into today is, well, it's a bit of a philosophical shift, isn't it?
How do you mean?
Moving from just thinking local control,
Mm-hmm.
to integrating systemic therapy much earlier, upfront for those higher risk patients.
Okay, thinking more systemically from the start.
Precisely. So the goal today, board ready, clean takeaways, those one-liners you need, but really grounded in the major trial data.
Perfect. And just a quick reminder for everyone listening, you can find tons of great practice materials like practice oral boards for GYN and other sites over at radonsmartlearn.com.
Definitely worth checking out for exam prep or just sharpening skills.
So we've got two key clinical scenarios to kind of anchor our discussion today. Makes it more concrete, right?
Always helps.
First up, a 62-year-old woman, newly diagnosed, FIGO stage 3B disease. She's about to start definitive therapy. The question for her is, what can we add today to enhance her outcome? What's the best strategy?
Okay, classic high-risk scenario.
Second scenario, metastatic recurrence. We've got a 55-year-old. She's 2 years out from her initial chemo RT for stage 2B disease. Now, unfortunately, she has a biopsy-proven lung met. For her, the question is, what's the modern, evidence-based, first-line systemic regimen?
Two very common, very important clinical questions right now.
Exactly. So let's start at the beginning.
Yeah.
Lay the foundation. Work up and the standard definitive therapy backbone.
Right. Before we even think about adding anything fancy, we have to get the basics perfect. So our mini algorithm, step 1, is diagnosis and staging, non-negotiable.
Which means what exactly?
It means a thorough history and physical H&P, obviously, and critically, a confirmed biopsy. You need that tissue diagnosis.
Got it. And then imaging. That's changed a bit with the newer FIGO staging, hasn't it?
It really has. The 2018 FIGO staging relies heavily on imaging. So for the local extent, how big is the tumor? Is it invading the bladder or rectum, parametrial involvement? You absolutely need a high-quality pelvic MRI that really defines your T stage.
Okay. MRI for local detail. What about nodes and distance spread?
That's where PET-CT comes in. It's essential for assessing nodal status, which now upstages patients to stage 3C if positive, and for detecting distant metastases, which is stage 4B, gives you the full picture.
So you gather all that H&P, biopsy, the pelvic MRI, the PETT, and then you assign the official FIGO 2018 stage.
Correct. And that stage then tells you who needs definitive chemoradiation therapy.
Which is generally who?
Generally, it's for locally advanced disease. So that includes FIGO stage 1B2, 1B3, stage 2, stage 3, stage 4A, or any stage 3C, meaning any patient with positive pelvic or para-aortic nodes confirmed on imaging.
Okay. So once we know they need chemo RT, let's define that standard backbone precisely.
The standard backbone, the absolute must-haves. First, external beam radiation therapy, EBRT, to the pelvis. The typical dose is 45 to 50.4 gray, usually delivered in 25 to 28 fractions.
Standard fractionation. But what about those positive nodes we might see on the PT?
Great point. If you have gross pelvic nodes confirmed on imaging, the standard now is to address them more aggressively during the EBRT. We typically use what's called a simultaneous integrated boost, or SIB.
So boosting the dose to the nodes at the same time.
Exactly. While you're delivering the 45 or 50.4 gray to the pelvis, you simultaneously escalate the dose to those visible, gross nodal volumes. The target dose for the SIB is usually around 55 to 60 gray.
Okay. Higher dose to the known disease. And this all happens concurrently with?
Concurrent chemotherapy. And the standard here hasn't changed in decades. It's cisplatin.
Still cisplatin. What's the dose and schedule?
40 milligrams per meter squared, given IV, weekly, throughout the entire course of EBRT.
40 weekly. Important to remember that, not the higher doses used in some other setting. It's purely for radiosensitization here.
Precisely. It's a potent radiosensitizer, and the weekly schedule is generally well tolerated enough to allow completion of radiation without excessive breaks.
Right, eberate with SIB if needed, plus weekly cisplatin. Now, what's arguably the most critical component for cure in cervical cancer?
Yes, brachytherapy. This is not optional, it's the cornerstone. Specifically, image-guided high-dose rate, or HDR, brachytherapy.
Why is it so crucial?
Because it allows us to deliver a massive, highly conformal dose right to the tumor, to the high-risk clinical target volume, or HRCTV, while minimizing dose to the surrounding bladder and rectum. It's the key to getting that high local control rate.
And there's a specific dose target we're aiming for, like
Yeah.
a benchmark.
Absolutely. The critical dosimetric target, the one you need to know for boards in clinic, is achieving a cumulative HRCTV D90, meaning 90% of that high-risk volume gets at least this dose of approximately 85 to 90 gray EQD2.
85 to 90 gray EQD2. And EQD2 stands for?
Equivalent dose in 2 gray fractions. It's a way to biologically standardize the dose delivered by EBRT, which uses small fractions, and brachytherapy, which uses very large fractions per session.
And calculating the EQD2 requires an assumption about the tumor sensitivity, the alpha-beta ratio.
Yeah. Correct. For tumor control, especially squamous cell carcinoma, which is most common here, we generally use an alpha-beta ratio of 10.
Okay, alpha-beta of 10 for tumor. So how do we actually get to that 85-90 gray EQD2 target with HER brachy? What are the common schedules?
There's some flexibility, but the goal is that dose. Common HDR schedules include delivering 6 grays per fraction for 5 fractions,
6 times 5.
or 7 grays per fraction for 4 fractions,
7 times 4.
or sometimes, maybe a bit less common but still used, 8.5 gray times 3 fractions.
8.5 times 3. Got it. Different ways to get to that critical target.
Yes, exactly. The choice might depend on the center, the patient's anatomy, logistics, but hitting that 85 to 90 gray EQD2 to the D90 is paramount.
This brings us back to something you mentioned earlier, the importance of timing. The overall treatment time, or OTT.
Yes, this is absolutely fundamental, non-negotiable. The historical data is incredibly strong on this. The entire course of treatment, from the very first day of EBRT to the very last fraction of brachytherapy, must be completed in less than or equal to 56 days, 8 weeks.
56 days. Why is that cutoff so strict?
Because beyond that point, we know that tumor cell accelerated repopulation kicks in. The cancer cells start dividing faster, essentially outrunning the treatment. Extending treatment beyond 56 days significantly compromises local control and ultimately survival. OTT discipline is job one.
Okay, efficacy is key, but we also need to consider the long-term effects. Brachytherapy puts high dose near critical organs, so OAR constraints are vital.
Absolutely critical for quality of life. We have mandatory organ at risk, or OAR, constraints that we must respect during brachytherapy planning.
And when we calculate the EQD2 for these normal tissues, we use a different alpha-beta ratio, don't we?
Yes, that's important. For normal tissues, like the bladder and rectum, which have slower repair mechanisms, we typically use an alpha-beta ratio of 3 for the EQD2 calculation. This gives us a better estimate of the risk of late toxicity.
Alpha-beta 3 for normal tissues. Okay.
So,
So what are the hard limits, the main dose constraints we need to know?
the key ones are for the bladder and the rectum sigmoid bowel. We look at the D2cc. That's the maximum dose received by any 2 cubic centimeters of the organ.
D2cc, what are the limits?
For the bladder D2cc, the limit is less than or equal to about 90 gray EQD2 using alpha-beta 3.
Okay, under 90 for bladder.
For the rectum, sigmoid, and bowel combined, the D2cc limit is less than or equal to 75 gray EQD2.
Under 75 for rectum and bowel.
And this is a really important clinical pearl. While 75 gray is the limit for the rectum, we really strive to keep the rectum D2cc lower whenever possible, ideally less than about 65 gray EQD2.
Why the push to go lower than the limit for the rectum specifically?
Because the data strongly links lower rectal DPCC doses, particularly below 65 gray, with significantly reduced rates of late rectal toxicity, like bleeding, urgency, and other functional problems, it makes a huge difference to long-term quality of life if you can achieve it safely.
Okay, so we've nailed down the standard backbone. 45-50.4 gray EBRT, maybe in SIB. Weekly cisplatin at 40. Crucial image-guided HDR brachytherapy aiming for 85-90 gray EQD2 D90. And the whole thing done in under 56 days, respecting OAR limits like keeping the rectum below 65 gray if possible.
That's the foundation. Absolutely solid.
Now, the exciting part. How do we enhance this? Make it better? We've got 2 major practice-changing strategies from recent trials, but And this is key. We can't just stack them by default, right?
That's the crucial caveat. We have two new tools, but they weren't tested together, so you have to choose one thoughtfully.
Let's break them down. Enhancement strategy 1, this was the big one, immunotherapy. Tell us about the Keynote A18 trial.
Keynote A18 was revolutionary, really. It tested adding the immune checkpoint inhibitor, pembrolizumab, directly to the standard definitive chemoradiation backbone.
Who was eligible for this trial? Which patients were they targeting?
They focused on patients considered high risk for recurrence based on the older FIGO 2014 staging used at the time. This includes stage 1B to 2B disease if they had positive pelvic nodes, or anyone with stage 3 to stage 4A disease. Basically, patients needing more than just local therapy.
Okay, so the higher risk group, what exactly was the pembrolizumab regimen? How was it given?
It's a bit complex because it has two phases. First, pembrolizumab is given concurrently during the chemo-RT. The dose was typically 200 milligrams IV every 3 weeks, which usually works out to about 5 doses during the standard EBRT course.
Concurrent phase first. Then what?
Then, if the patient tolerated the concurrent phase well, they continued with adjuvant pembrolizumab. The dose here was 400 milligrams IV every 6 weeks. The goal was to complete about 1 full year of immunotherapy in total, counting both phases.
A full year. That's a significant commitment. What was the thinking behind that concurrent plus adjuvant approach?
The idea, the hypothesis, was that radiation might act like an in situ vaccine, damaging the tumor releases antigens, potentially making it more visible to the immune system. Giving pembrolizumab concurrently might enhance that initial immune response, and then continuing it adjuvantly maintains that immune pressure long-term to hopefully mop up any residual microscopic disease.
And did it work? What were the results?
It absolutely worked. The trial showed a significant, quite dramatic improvement in progression-free survival, PFS, for the patients who got pembrolizumab compared to placebo.
Wow, okay. PFS benefit clear. What about overall survival?
The overall survival data is still maturing, but it's definitely showing a very promising trend favoring the pembrolizumab arm. It's clearly beneficial, which is why this became a new standard of care option.
Now, a really critical point for exams and practice. Do you need to check PD-L1 status before starting pembro in this definitive setting, like we do for metastatic disease?
Excellent question, and the answer is a firm no. This is different from the metastatic setting. For Keynote A18, in the definitive locally advanced setting, PD-L1 testing is not required.
Why not?
The benefit was seen across the board in the high-risk population, regardless of their baseline PD-L1 status. It suggests that the chemoradiation itself likely induces enough inflammation or changes the tumor microenvironment sufficiently that the immunotherapy works even if the baseline PD-L1 is low or negative.
Okay, that's a key distinction. No PD-L1 test needed for A18. Let's talk logistics. Adding 4V infusions every 3 weeks during chemo-RT and then every 6 weeks after. That sounds complex to schedule around radiation and especially brachytherapy while still meeting that 56-day OTT.
It requires very careful planning and coordination. You need your IMRT plan locked down, and you need tight communication between radiation oncology and medical oncology. The pembro infusion scheduling cannot, under any circumstances, delay the start of brachytherapy or push the overall treatment time beyond 56 days.
Because that would potentially negate the benefit.
Exactly. You'd undermine the foundational principle of timely local therapy.
What about toxicity? We're adding potential immune-related side effects onto the known toxicities of chemo-RT.
Right. You have to be vigilant for both. You expect the usual chemo-RT side effects, fatigue, diarrhea, cystitis, some myelosuppression. But layered on top, you're looking for immune-related adverse events, or IRAEs.
What are the common IRAs to watch for?
Most common are probably GI issues like colitis, skin rashes, and endocrine problems, especially thyroiditis, either hypo or hyperthyroidism. But you also have to watch for more serious things like pneumonitis, which is lung inflammation, and hepatitis presenting as elevated liver enzymes or transaminitis.
So how do you monitor for these?
Proactive monitoring is key. You need baseline labs before starting definitely a CBC, a comprehensive metabolic panel, CMP, to check liver and kidney function, and thyroid function tests, TSH and free T4. And then you need to repeat these periodically throughout treatment.
And what do you do if you suspect an IRAE?
The threshold to act should be low. If a patient develops symptoms suspicious for an IRAE, like worsening diarrhea, a new rash, shortness of breath, persistent fatigue, you need to hold the pembrolizumab and strongly consider starting high-dose steroids fairly quickly, often after discussion with medical oncology. Don't wait for it to get severe. Early intervention is key.
Okay, so Keynote A18 gives us our immunotherapy enhancement option. Concurrent plus adjuvant pembro for about a year, No PD-L1 needed, improves PFSOS, but watch OTT and IRAEs.
That's the summary.
Now let's talk about the other new way to enhance outcomes. Enhancement Strategy 2, Induction Chemotherapy, based on the Interlace trial.
Right. Interlace took a different approach. Instead of adding something during chemo-RT, it tested giving a short course of chemotherapy before starting the standard chemo-RT.
Induction chemo. That concept isn't entirely new for cervix cancer, is it? Hasn't it been tried before without much success?
You're right, it has. Older trials using different induction regimens, often more toxic ones like cisplatin-5FU, didn't consistently show a benefit and sometimes caused delays starting chemo-RT due to toxicity. Interlace was designed differently.
How so? What was the induction regimen in Interlace?
They used a relatively well-tolerated, convenient regimen. Weekly paclitaxel at about 80 milligrams per meter squared, plus weekly carboplatin dose at an AUC of 2. And importantly, they only gave it for 6 weeks.
6 weeks of weekly Taxol carbo. Then what?
Then, immediately, like the very next week, patients started standard definitive chemoradiation therapy with weekly cisplatin, exactly as we discussed before. No planned gap between induction and chemo-RT.
Okay, short induction, better tolerated drugs, immediate transition. Did this approach work?
Yes, it did. The Interlace trial showed a statistically significant improvement in both overall survival and progression-free survival compared to giving standard chemo-RT alone.
An overall survival benefit, that's the gold standard. How big was the improvement?
It was clinically meaningful. They reported an absolute gain of about 8% in overall survival at 5 years for the induction group. Getting an OS benefit like that in a large randomized trial for locally advanced cancer is a big deal.
8% absolute gain in OS at 5 years.
Wow. So who might be the best candidate for this interlace strategy? When might you choose this instead of the A18 approach?
Good question. While there's no definitive head-to-head comparison, clinicians often consider interlace for patients who are fit enough for it and who present with particularly bulky disease, either a very large primary tumor or significant pelvic lymph node involvement, maybe multiple bulky nodes.
Why those patients specifically?
The thinking is that the induction chemo might help shrink the tumor burden up front, potentially making the subsequent radiation, especially the brachytherapy implant, more effective or easier to deliver optimally. It might also hit microscopic distant disease harder and earlier. Makes sense. But this brings us back, maybe even more intensely, to that critical operational rule, the overall treatment time. You've just added 6 weeks of treatment before the clock even starts on chemo-RT.
This is the absolute non-negotiable rule for interlace. If you choose this strategy, you must adhere strictly to starting the chemo-RT the week immediately following the last induction dose. And then, the clock for the chemo-RT portion, the EBRP plus brachytherapy, still has to be 56 days or less.
So the induction phase doesn't buy you extra time for the radiation phase?
Not at all. You cannot let the induction phase lead to delays in starting or completing the curative radiotherapy component. If you violate the 56-day OTT for the chemo-RT part, you likely lose the survival advantage demonstrated in the trial. Discipline is paramount.
Okay. What are the main side effects to anticipate during those 6 weeks of induction Taxol carbo?
It's standard platinum and taxane toxicity, just front-loaded, so you're monitoring for myelosuppression effects on blood counts. Peripheral neuropathy from the paclitaxel can be dose-limiting for some patients, and fatigue is common, but generally it's manageable enough to allow the immediate transition to chemo-RT for most fit patients.
All right, let's explicitly tackle the elephant in the room, the do not stack caveat. We have A18 showing benefit from concurrent adjuvant pembro. We have interlace showing benefit from induction chemo. Why can't we just do both for our highest risk patients? Give them induction, then chemo-RT with pembro, then adjuvant pembro.
Because it simply hasn't been tested prospectively. We have zero data on the safety or efficacy of combining those two intensive strategies.
What are the potential concerns?
The potential for overlapping and synergistic toxicities is significant. Imagine 6 weeks of Taxol carbo, immediately followed by 7 weeks of cisplatin-RT plus pembro, then nearly a year more of pembro. The cumulative hematologic toxicity, GI toxicity, risk of severe immune-related events. It's just unknown territory and potentially very risky.
So the current standard is you have to choose one enhancement strategy or the other based on the available data.
Exactly. The decision needs to be thoughtful. It should probably involve a multidisciplinary tumor board discussion, considering the patient's specific disease characteristics, bulk versus just high stage, their overall fitness, logistical factors at your center, and maybe even patient preference after discussing the pros and cons of each approach. You pick one evidence-based enhancement, either A18 or interlace. You don't combine them outside of a clinical trial.
Okay, let's bring this back to our first patient. Clinical case application 1. The 62-year-old woman with newly diagnosed FIGO stage 3B disease. She's ready to start definitive therapy. Based on everything we've just discussed, what can you add to her standard chemo-RT today that has proven to improve outcomes?
All right, standard chemo-RT is the mandatory foundation, as we established. Since she's stage 3B, she clearly falls into that high-risk category, eligible for enhancement based on both recent trials.
So she qualifies for either approach.
Yes. She would have met eligibility for Keynote A18, stage 3 disease, and likely would be considered for interlace given stage 3B often implies significant local extent.
So how do we choose? If this were a board question asking what enhancement is supported by Keynote A18 specifically?
If the question specifically points to Keynote A18, then the answer is clear. You would add pembrolizumab concurrently during her chemo-RT, and then continue it adjuvantly aiming for about 1 year total duration. That's the A18 regimen, reflecting MCQ1 answer C.
And the rationale is the proven PFS benefit and emerging OS benefit shown in that trial for this patient population.
Precisely. Alternatively, based on interlace, giving her 6 weeks of induction paclitaxel carboplatin immediately before starting the standard chemo-RT, while respecting the OTT, would also be a valid, evidence-based enhancement strategy aiming for improved OS and PFS. But again, not both.
Got it. Choose one lane. Okay, let's imagine our patient completes her treatment, perhaps with the A18 approach. How do we assess her response and predict her long-term prognosis? You mentioned clinical exam isn't great right after treatment.
Right, there's too much inflammation immediately post-treatment. The single most valuable tool for assessing response and providing prognostic information is the PET-CT scan performed approximately 3 months after finishing all therapy, EBRT, and brachytherapy.
The 3-month PET-CT, how predictive is it?
It's incredibly predictive. If that 3-month PET-CT is completely negative, meaning no abnormal FDG uptake in the pelvis where the tumor was, no suspicious nodes, nothing distant that signifies an excellent prognosis.
Oh, excellent.
We're talking in the range of about 80% 5-year cancer-specific survival for patients with a negative 3-month PTT. It's a huge reassurance for the patient and the treating team.
That's powerful. What if the PT isn't negative? What if there's still uptake?
That requires immediate action. If there's persistent FDG uptake within the treated field, the cervix, uterus, parametria, or treated nodes, you have to suspect residual or recurrent disease. This usually warrants evaluation for a biopsy to confirm. If viable cancer is found, you then have to consider salvage options, which might include surgery, like pelvic exoneration, a major undertaking, or sometimes reirradiation, though that's complex.
And what if the uptake is outside the pelvis, somewhere new?
If the 3-month PT shows new FDG-avid lesions outside the treated pelvic field, say in the lungs, liver, or distant nodes that indicates metastatic recurrence or progression, this triggers a workup for systemic disease, usually restaging imaging, a biopsy of the new lesion to confirm metastasis and maybe get tissue for molecular testing like PDL1, and then starting systemic therapy based on those findings.
Okay, let's quickly address a common question. What about giving more chemotherapy after completing curative intent chemo-RT and brachytherapy? Is there a role for routine adjuvant chemo?
That's a definite no, based on high-level evidence. The Outback trial was a large randomized study specifically designed to answer this question. It compared standard chemo-RT versus chemo-RT followed by 4 cycles of adjuvant carboplatin and paclitaxel.
And the result?
The result was clearly negative. Adding the adjuvant chemotherapy provided absolutely no improvement in either progression-free survival or overall survival, but it did add toxicity. So the standard is clear. No routine adjuvant chemotherapy after completed chemo-RT for locally advanced cervical cancer.
Good to know. Okay, the patient finishes treatment, the 3-month PET is negative. Fantastic news. Now we shift focus to long-term survivorship care. What are the essential components we, as radiation oncologists, need to proactively manage?
Survivorship is crucial. A major issue after pelvic radiation, especially with brachytherapy, is vaginal stenosis, scarring, and narrowing of the vagina. So implementing a mandatory vaginal dilator program is essential.
When should that start and how often?
It should typically start about 1 to 2 weeks after the final brachytherapy fraction once the acute inflammation has subsided a bit. Patients need clear instructions and encouragement to use the dilators regularly, usually 3 to 5 times per week, essentially indefinitely, to maintain vaginal patency and function.
Okay, dilator program is key. What else?
We need ongoing management and counseling for potential late effects on bowel and bladder function, things like chronic diarrhea, urgency, or radiation cystitis. Bone health is another important aspect, especially if the patient was premenopausal and the radiation effectively ablated ovarian function, putting her into early menopause. We need to think about bone density screening and potentially hormone replacement therapy or bisphosphonates.
And lymphedema?
Yes, lymphedema risk, particularly if the patient had extensive nodal radiation or a prior lymph node dissection. Patient education on risk reduction strategies, recognizing early signs, and referral to lymphedema therapy specialists if needed is very important.
All right, let's pivot now to our second case scenario, the patient with metastatic recurrence. This brings us to mini algorithm step 6, managing metastatic or recurrent disease. The landscape here has also changed dramatically, hasn't it?
Absolutely, driven largely by immunotherapy integration, similar to the definitive setting, but with some key differences.
What's the very first decision point when you encounter a patient with recurrent or metastatic cervical cancer who needs systemic therapy?
The absolute first step before choosing any drugs is to determine the tumor's PD-L1 status. Specifically, we need the combined positive score, or CPS.
The PD-L1 CPS score. Why is that the critical first step?
Because the optimal first-line systemic therapy regimen is now dictated by whether that CPS score is 1 or greater versus less than 1.
Okay, let's take the favorable scenario first. The patient's tumor is PD-L1 positive, meaning CPS is 1 or greater. What's the standard first-line treatment?
For PD-L1 positive, CPS-1, recurrent metastatic cervical cancer, the first-line standard of care is based on the KEYNOTE-826 trial. It's a combination of pembrolizumab plus platinum-based chemotherapy, usually cisplatin or carboplatin, plus paclitaxel. And importantly, you can add bevacizumab to this combination if the patient is eligible for it.
So, potentially a 4-drug regimen, pembro plus platinum plus taxane plus bev.
Potentially, yes. KEYNOTE-826 showed that adding pembrolizumab to the chemo backbone, with or without bev, significantly improved both PFS and, crucially, overall survival compared to chemo, with or without bev, alone in this PD-L1 positive population.
And the pembrolizumab dosing in this metastatic setting, is it the same as A18?
It's typically given either as 200 milligrams IV every 3 weeks to align with the usual 3-week chemo cycle, or sometimes as 400 milligrams IV every 6 weeks.
Okay, so PD-L1 positive CPS-01 gets pembro plus chemo plus Ang-A-Bev. Now, what about the other scenario? What if the tumor testing comes back PD-L1 negative, CPS less than 1?
If the CPS score is less than 1, the significant benefit from adding pembrolizumab seen in KEYNOTE-826 wasn't really observed. So in this PD-L1 negative group, the first-line standard of care reverts back to the regimen established by the earlier GOG 240 trial.
Which was?
Platinum-based chemotherapy, cisplatin or carboplatin, plus paclitaxel, plus bevacizumab, assuming the patient is eligible for bevacizumab. Basically, chemo plus bev without the immunotherapy.
Can you give us a concrete example of that chemo plus bev regimen?
Sure. A common GOG 240-based regimen would be something like cisplatin 50 milligrams per meter squared on day 1, plus paclitaxel maybe 135 to 175 milligrams per meter squared on day 1, given every 3 weeks. And then bevacizumab added at 15 milligrams per kilogram, also IV every 3 weeks.
You've mentioned bevacizumab eligibility a couple of times. It's not for everyone, especially after pelvic radiation. What are the key criteria and risks?
Right. Bevacizumab is an anti-angiogenic agent. It targets VEGF. It's effective, but it comes with specific risks, especially relevant in GYN cancers often treated with prior RT. The main prerequisites for using it are no active fistula or high risk of perforation, like recent bowel surgery or known tumor invading bowel bladder wall, and the patient's blood pressure must be well controlled, generally below 14/90.
And the toxicity profile. What are the unique bevacizumab pearls?
Key toxicities include hypertension. You have to monitor blood pressure closely. Proteinuria, checking urine protein is important. There's an increased risk of bleeding, so careful counseling is needed. But the biggest concern, particularly post-pelvic radiation, is the increased risk of GI or GU fistula formation.
Fistulas. How does bevacizumab cause that?
It inhibits blood vessel formation, which is great for stopping tumor growth, but it also impairs normal wound healing. In areas previously damaged by radiation, this can sometimes lead to the breakdown of tissue between organs, creating abnormal connections like a hole between the rectum and vagina, rectovaginal fistula, or bladder and vagina, vesicovaginal fistula. It's a serious complication.
Definitely something to counsel patients about extensively. Okay, so that covers first line. What if a patient progresses after these initial therapies? Are there further options?
Yes, there are approved options for second line and beyond, though response rates tend to be lower. One option is cemiplimab, which is another PD-1 inhibitor, interestingly approved regardless of PD-L1 status in the second line setting based on its own trial data.
Okay, cemiplimab. Any others?
Another important agent is tisitum vedotin. This is an antibody drug conjugate, or ADC. It targets tissue factor, which is often expressed on cervical cancer cells, and delivers a potent chemotherapy payload directly to the tumor.
Tisotumab vedotin. I feel like there's a specific major toxicity warning associated with that one.
Absolutely. This is a critical toxicity pearl. Tisitumab vedotin has a significant risk of causing ocular toxicity problems with the eyes, including keratitis, corneal inflammation, conjunctivitis, pink eye, dry eye, and even vision changes.
So how is that managed? It sounds serious.
It requires an absolutely mandatory, strict ocular toxicity prevention program. This isn't optional, it's part of the drug's label and REMS program. Patients must adhere to a rigorous protocol involving specific eye washes, steroid eye drops, and vasoconstrictor eye drops, starting before their first infusion and continuing throughout treatment. They also need regular scheduled eye exams with an ophthalmologist to monitor for any early signs of damage.
Wow, mandatory eye care protocol. That's crucial to remember for tisotumab.
Non-negotiable if you're using that drug.
Okay, let's apply this to our second case. Clinical case application 2. The 55-year-old woman with the recurrent lung metastasis. Her biopsy comes back PD-L1 positive with a CPS score of, let's say, 15. What's her first-line systemic therapy?
All right, CPS is 15, which is definitely 1 or greater. So based on Keynote 826, her standard first-line regimen is pembrolizumab plus platinum and taxane chemotherapy. And you would strongly consider adding bevacizumab as well, assuming she has no contraindications like fistula risk or uncontrolled hypertension, reflecting MCQ2 answer C.
Pembro plus chemo plus last bev. Got it. And just a quick thought, if she only had that single lung met and oligometastasis, would local therapy ever play a role?
That's a great point. Well, systemic therapy is the absolute backbone for metastatic disease. If a patient has very limited metastatic burden, say, 1 or maybe 2 spots easily targetable, like a single lung met there, is growing interest in considering adding local therapy, like SBRT, stereotactic body radiation therapy, to those spots. The idea is maybe to improve local control at the metastatic site, potentially delay progression, or even achieve a longer treatment-free interval down the line. It's often discussed at tumor board, but systemic therapy remains the primary treatment.
Okay, we have covered a ton of ground. From the standard chemo-RT backbone to the major enhancements with A18 and interlace and the new PD-L1-driven approach for recurrence. Let's try to boil this down into the absolute must-know clinical pearls. 5 key takeaways.
Let's crystallize them.
Ready? Pearl number 1. Summarize Keynote A18 for me.
A18. For high-risk, locally advanced disease, like stage 3 to 4A, adding pembrolizumab concurrently during chemo-RT and continuing adjuvantly for about 1 year total improves outcomes. PFS strongly, OS emerging. Crucially, PD-L1 testing is not required in this definitive setting.
Got it. Pearl number 2. The interlace summary.
Interlace. 6 weeks of induction chemo with weekly paclitaxel plus carboplatin, followed immediately by standard chemo-RT, improves overall survival. The absolute key operational rule: maintain the overall treatment time, OTT, for the chemo-RT phase at less than or equal to 56 days. No delays.
Perfect. Pearl number 3. The rule for metastatic first-line therapy.
Metastatic rule. It's all about PD-L1 CPS. If CPS is 1 or greater, first line is pembrolizumab plus platinum taxane chemotherapy, with or without bevacizumab. If CPS is less than 1, first line is platinum taxane chemotherapy plus bevacizumab, if eligible.
Clear algorithm. Pearl number 4. Prognosis after treatment.
Prognosis. The PET-CT scan done about 3 months after completing chemo-RT is a very powerful prognostic indicator. A negative 3-month PT means an excellent outlook, around 80% 5-year cancer-specific survival.
Excellent news when it's negative. And finally, pearl number 5, the big caveat.
The caveat: the Keynote A18 regimen, immunotherapy, and the interlace regimen, induction chemo, have not been tested together. Do not stack these 2 enhancement strategies by default outside of a clinical trial. Choose one thoughtfully.
Fantastic summary. 5 pearls to lock away. Now let's put this into practice with our board review segment. 4 rapid-fire multiple-choice questions. You ready?
Let's do it.
MCQ 1, revisiting case 1. A 62-year-old with stage 3B disease starts definitive therapy. What enhancement strategy is specifically supported by the Keynote A18 trial? A. Adjuvant chemotherapy for 4 cycles. B. An SBR2 boost instead of brachytherapy. C. Pembrolizumab concurrently, then adjuvantly to about 1 year. Or D. A planned treatment break of 4 weeks.
The answer is C, rationale. Keynote A18 established the benefit of adding concurrent and adjuvant pembrolizumab for about a year to standard chemo-RT for high-risk locally advanced disease, stage 3-4A, improving PFS with an emerging OS benefit.
Correct. MCQ2, based on case 2. A fit 55-year-old has recurrent metastatic disease with a PD-L1 CPS of 1 or greater. What is the modern first-line systemic therapy? A. Platinum and taxane alone. B. Platinum and taxane plus bevacizumab. C. Pembrolizumab plus platinum and taxane with or without bevacizumab. Or D. Tisodium bevacizumab.
The answer here is C again. Rationale. Keynote 826 showed that for CPS ERA-1 patients, adding pembrolizumab to the chemo backbone plus NASH bevacizumab significantly improves overall survival in the first-line metastatic setting.
That's exactly. MCQ3, focusing on interlace. You're considering induction chemotherapy for a patient with a bulky stage 3C1 tumor. Based on the interlace trial, what's the correct regimen and the crucial operational rule? A. Cisplatin-5 for 3 cycles, then a 4-week break before chemo-RT. B. Weekly paclitaxel, 80 mm 6 plus carboplatin AUC2 for 6 weeks, then immediate chemo-RT maintaining OTT, 56 days. C. Gemcitabine for 2 cycles, then immediate chemo-RT. Or D. Weekly paclitaxel carboplatin for 12 weeks to maximize response.
The answer is B. Rationale. Interlace used the 6-week weekly paclitaxel carboplatin regimen and demonstrated an OS benefit, but this benefit is contingent on the non-negotiable rule of immediate transition to chemo-RT and strict adherence to the 56-day OTT for the radiation phase to avoid compromising local control.
Perfect. Final question, MCQ4, hitting on toxicity. Which systemic therapy agent used for recurrent metastatic cervical cancer requires a mandatory ocular toxicity prevention program, including a strict eye wash eye drop protocol and scheduled eye exams?
That specific requirement points directly to tisotumab vedotin. Rationale. Managing the significant risk of ocular toxicity is an essential, mandatory part of administering this antibody-drug conjugate. #outro.
Wow. That was definitely a comprehensive session covering the major shifts in cervical cancer management. A lot to process, but incredibly important updates.
It really is a new era. We've solidified that standard chemo-RT backbone, but now we have these proven ways to intensify treatment for higher-risk patients right from the start, layering pembrolizumab based on Keynote A18.
Or using that specific interlace induction protocol, but only if you maintain absolute discipline with the overall treatment time. That 56-day rule keeps coming up.
It's fundamental. And then in the metastatic setting, that clear PD-L1-driven algorithm based on Keynote 826 for first-line therapy, it really clarifies the approach.
Plus reinforcing the huge prognostic value of that 3-month post-treatment PET scan, and remembering the critical toxicities like the Bev fistula risk or the tisotumab eye issues.
These are the upgrades that truly matter, both for board exams and, more importantly, for improving outcomes for our patients in the clinic.
Absolutely. And if you want to solidify this knowledge further, practice applying it in different scenarios, definitely check out the practice oral boards and other resources over at radoncSmartLearn.com.
Continuous learning and practice are key in our field, especially when things change this rapidly.
So, as a final thought to leave everyone with, we've talked about A18, immunoconcurrent adjuvant, and interlace, induction chemo, as separate, proven strategies. We know we can't stack them now.
Right.
But what's the next frontier?
That's the big question, isn't it? If both strategies work through potentially different mechanisms, one boosting long-term immune surveillance, the other hitting hard upfront systemically, will future trials eventually show that the highest-risk patients actually need both? Perhaps a short induction followed by immunochemo-RT and then maintenance. Combining these powerful tools safely and effectively, that's likely where the research is heading.
Fascinating possibility to keep an eye on. Well, thank you so much for that incredibly detailed breakdown today.
My pleasure. Always good to review these critical updates.
And thank you all for joining us. Make sure you subscribe to Right On Smart Review for our next session. We'll be shifting gears completely to tackle endometrial cancer, diving into the subtypes, the game-changing 2023 molecularly integrated FIGO staging, and exploring exactly how knowing the molecular class fundamentally reshapes adjuvant treatment decisions. It's another area undergoing massive changes. Thanks for tuning in.